Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I am going to discuss initial assessment in suspected acute stroke. Stroke, by definition, is a neurological deficit of vascular origin. There are many mimic strokes. Examples are the Todd's palsy following a seizure, syncope, hypoglycemia. Early assessment is crucial as time is spring. The goals of initial evaluation: first is ABC, airway, breathing, circulation. Second is identify reversible causes rapidly, example hypoglycemia. Third, identify candidates for thrombolysis and mechanical thrombectomy. Fourth, divide the stroke into ischemic, hemorrhagic, or is it a stroke imitator. Now we go for the stabilization. Assess the vitals immediately. Early intubation if there is decreased consciousness, bulbar dysfunction, and airway is at risk. Hypoventilation may increase intracranial pressure, and so this should be corrected. See that the SpO2 is more than 94. Oxygen is given if SpO2 is less than 94. Avoid oxygen routinely in non-hypoxemic patients. And a single dose of IV ceftriaxone 2 grams if intubated. And it has shown to reduce the ventilator-associated pneumonia and mortality. Do a quick physical examination and history. Symptom onset time is the most important. When did the problem start? In order to identify whether it is a candidate for thrombolysis, that is a window period less than 4.5 hours. And I also identify when the patient was last normal. Is it before 24 hours? Because such patient may be a candidate for thrombectomy. Verify whether the patient is on anticoagulants, insulin, because the risk of hyperglycemia and a history of stroke, a seizure should also be asked for. And exclude clinically subarachnoid hemorrhage and intracranial hemorrhage, looking at the clues like sudden severe headache or significant vomiting and altered consciousness. Now, quick physical examination. Look for vascular signs like bruise and absent pulses. Vascular for carotid bruit, vertebral bruit. Examine the heart for cardiac murmurs and examine the pulse for atrial fibrillation. Expose the skin and see whether there is skin signs of embolic phenomena, infective endocarditis. That is features of cholesterol emboli, the stigmatas of endocarditis, any purpura. Exclude trauma. Look for head injury, the features of trauma in the head, tongue bite, examine the neck. And a rapid neurological examination. Use the standardized NIH stroke scale. There are 11 items. Stroke is considered as mild if the score is less than 5, moderate 5 to 9, and severe it is more than 10. 3 predictors of stroke: facial paresis, arm drift, abnormal speech. We can remember the B fast. F for the face, A for arms, S for the speech, T is for the time. B stands for the balance and eyes. That is the B fast. But again, remember the NIH stroke scale. Many posterior circulation strokes are missed or not represented properly. The neurological examination includes, as mentioned, the above things. So, most important point to remember is posterior circulation strokes may be missed by NIH score. Essential investigations: a random lecture before sending the patient for imaging. check the SpO2, and a non-contrast CT is the minimum. CT scan is done to rule out hemorrhage and guides decision for thrombolysis. Don't delay the treatment waiting for other tests. So only these basic tests are required initially. So in conclusion, a rapid structured approach saves neurons. Think ABC, blood glucose, non-contrast CT, NIH score, NIH stroke scale. Treat what is treatable and move fast forward for definitive care. The thrombolytic therapy, mechanical thrombectomy, antiplatelets, anticoagulants, etc. will be discussed subsequently. Thank you.